Okay, so good afternoon, or just afternoon, and welcome to this town hall that's being co-hosted by the Perinatal Neonatal Quality Improvement Network of Massachusetts and the Betsy Lehman Center for Patient Safety. I'm Barbara Fain, the Executive Director of the Betsy Lehman Center, and once again, we're really happy to be partnering with PNQIN on this fourth weekly forum for on COVID-19 and pregnancy care. As usual, we have a really packed agenda. So I'm going to quickly turn things over to Audra Meadows, who, along with Ron Iverson, co-chairs the Massachusetts Perinatal Quality Collaborative. Before I do that, just a couple of housekeeping items. If you're having technical issues, as you can see, just send a chat message to Alex Zhang and she'll help you out. You also, we're going to be hoping to have a really robust question and answer dialogue at the end of this. And we encourage you to chat questions as we go along, and we will, after all of the presenters, we will turn to those. Finally, just want to mention that this meeting is being recorded, as are the chats. And if you have any concerns about recording, just send a chat to the Betsy Lehman Center. With that, let me turn things over to Audra.
Thank you, Barbara. Next slide, please. We're going to talk a little bit about where we are now with our state profile. So I want to say thank you to Dr. Fifi Jop from the State Department of Public Health, who's helped us to acquire data to look at the prevalence of the infection rates across Massachusetts by county. As many of you have heard through many news reports, according to the Johns Hopkins University tally, there's been more than 988,000 coronavirus cases across the US, and the death toll has now surpassed 56,000. Globally, there's been more than 3 million with a death toll of 211,000. Modeling for cases in Massachusetts predicts that this is yet another peak week along the mesa of our COVID-19 spread in Massachusetts. The prevalence of affected communities are shown here in shades of blue at rates per 100,000. There's over 46,000 confirmed cases in Massachusetts, which is actually only 5% of the coronavirus cases for the United States. The 43 birthing facilities that we work closely with across Massachusetts are represented here on this map in red and show they also match location for impact. Interestingly, we've heard outcomes collected by obstetrics units as they're responding to COVID-19 from academic centers. And today we're going to hear from Lawrence General Hospital, which is up more towards the north on the right, past into the Merrimack Valley, into the community that's impacted there, as you can see in dark blue. Next slide, please. Information that's been collected and outcomes from the Massachusetts Perinatal Nurses team reflect the population infection density that we also see in that prior slide. This shows some of the cases of deliveries for moms with COVID-19, and there can be more information discussed during question and answer regarding this information with Bonnie Glass during the Q&A period. Next slide, please. Some good news is that the testing capability continues to increase. As you can see, there's a notable spike on April 24th as test kits continue to grow. And we're going to hear today from Dr. Ilona Goldfarb about testing that's happening on labor and delivery units for universal screening as it's occurring. Next slide, please. And as you can see also from this data that can be accessed through the Massachusetts Department of Public Health website, one challenge is in the face of these vastly reported health disparities and outcomes is the lack of race and ethnicity data that we see here in Massachusetts. The light blue and these three pie charts represent data that is of unknown race and ethnicity. And that's going to be really important. It's important to have all information about race, ethnicity, region of geography, language, et cetera, as we think about equity in these issues. And as we move into late fall and winter 2020, we want to be able to offensively plan for targeted public health messaging, focused testing, and providing services. So with all that being said, next slide, please. Let's move into today's presentation to talk about how the family medicine services at Lawrence General Hospital are going to be managing COVID-19 and their response. And as well, I'd like to now introduce my colleague, Dr. Ilona Goldfarb, who's a maternal fetal medicine specialist at the Massachusetts General Hospital, who will discuss COVID-19 testing on labor and delivery, preparations and pitfalls. Dr. Goldfarb.
Thank you. Thank you so much. Barbara, Ron, Audra, everybody, for getting us all together here to share information. This has been so valuable for us at Mass General as well. And I'm happy to to be here to share our experience with COVID-19 testing on labor and delivery. Next slide, please. So I wanted to start with a question just to kind of anchor us and see what everybody's doing around the state. The question is, which testing strategy is most consistent with your practice on L&D? Universal testing of all patients arrive for admission, testing only symptomatic patients, testing all patients who are having procedures only, or testing all planned procedures and symptomatic patients. So we'll give it a little bit more time to get everybody's votes in. Great, so I think this spread really shows how much we're all just really working hard to try to figure out what's the best plan. You know, clearly a lot of people have moved towards universal testing, and I'm going to talk a little bit about how we rolled that out, but also a lot of our colleagues on the phone today are struggling with that and not yet doing universal testing in favor of other testing strategies. So the problem is that early on in the pandemic, we got news from New York City labor and deliveries that once they began universal testing, they identified 13% of asymptomatic patients showing up to L&D testing positive for COVID-19, and recognized that without being able to identify these patients based on symptoms, we weren't really able to protect our units, our moms and babies, and our staff. And so universal COVID-19 testing in L&D is now recommended at our center and other centers around the state and around the country. But there really hasn't been much guidance in terms of implementation or interpretation of these results, and both aspects can be complex. Next slide. So I think the most important thing for us to recognize as we think about introducing universal testing into our centers or processing through the results is to ask ourselves, what is the primary goal of universal testing? So these are some things, oopsies, sorry about that. These are some things that we feel are our objectives for universal testing. One is the appropriate isolation of COVID positive patients to decrease the risk of transmission within the hospital, and the appropriate utilization of PPE for these patients that we otherwise would not have identified. And it's also for protection for the newborns, thinking about separation within the room or temporary separation within the hospital. And then most importantly, the appropriate teaching of families of best practice for infection prevention in preparation for discharge. Next slide. So once we decided that we wanted to have this testing, we really weren't able to just press a go button and start testing. We had to think about how this was going to impact all of our services and think about how to make this efficient and feasible and practical. And so we pulled together a multidisciplinary team to think through these aspects. Importantly, labor and delivery and outpatient OB nursing staff were critical in thinking through this rollout. Infection control colleagues to help us with results review, obstetric, neonatal, and anesthesia providers that are impacted by this knowledge on labor and delivery. And really important was to engage with our order entry team in our electronic medical record, as well as the micro lab, to ensure that once these tests were ordered, that we were going to be able to have appropriate and timely results. Next slide. So L&D COVID testing really begins before L&D in the outpatient setting. We recognized that we couldn't roll this out without at least attempting to communicate with our patients that were still outpatients so that they could anticipate that this testing was happening and not be surprised on arrival. What we realized quickly and have been throughout this COVID crisis is it's really difficult for us to reach all of our patients. We don't have a really great way to blast out messages that are going to reach every single patient in our system. We did send out some blast message through the patient portal, but that's really limited to patients that have signed up for the communication through the portal, and was not everybody. We also asked providers to discuss this with all their patients in their visits, both in person and virtual, in the week leading up to rollout and on from there. We also initiated testing of all of our scheduled L&D admissions in advance. Patients were being sent to outpatient or drive-through testing sites 48 hours prior to their admission date. This too became obvious to us that not all patients had access to this. And actually, not all patients could just drive to a drive-through site. Some patients could not leave their homes. They were not able to drive. Their partner was an essential worker and at work until after hours. So we had to make accommodations, of course, and for patients who are unable to go to a drive-through or outpatient site, we're asking them to arrive earlier to labor and delivery so that we have time to obtain the tests. Next slide. So L&D COVID testing on admission to the labor floor really still begins with screening questions. So we're not just relying solely on the nasopharyngeal swab alone, but we really need to ask important questions. And these are the set of questions that everyone is asked. Number one, have you previously been tested negative in anticipation of this admission? Number two, have you previously been symptomatic and tested positive for COVID-19? We currently have quite a large cohort of outpatients that are COVID positive in various stages of recovery in the outpatient setting that at any point in time may be coming into labor and delivery. And then if patients are not previously COVID-19 tested, we ask about symptoms of COVID-19 now and in the days preceding this admission, and any known exposure to a confirmed COVID-19 patient. Based on answers to all of these questions, and then subsequently the L&D nasopharyngeal swab that we send, level of precautions that we use with this patient, and the mother and baby recommendations will follow. Next slide. So as in terms of our L&D workflow, the swabs are obtained upon admission by the labor and delivery triage nurse, and the providers place the COVID order with the admission orders. The swabs are then hand delivered to the micro lab. We recognize this after spending some time talking to the lab about how best to expedite these results. The micro lab prioritizes any samples sent from labor and delivery to the Cepheid testing platform. I'm by far not an expert on testing platforms, but I know now that there are many different platforms that the hospital is using, and Cepheid is one type that has a more rapid turnover. So our samples from labor and delivery are being prioritized to that platform, and the turnaround time is approximately 2 hours. Next slide. So quick poll question here. On your units, for patients that test negative for COVID-19 on L&D, when is enhanced respiratory isolation recommended? And by enhanced respiratory isolation, I mean N95 respirator or PAPR, along with gowns and gloves and eye protection. So are we using it for the entire labor admission regardless of the test results, only during deliveries of negative patients, never because the patient has tested negative, or only if the COVID negative patient develops new symptoms while on labor and delivery? This is great. So again, you know, what's so wonderful about these polls is so we can see and compare ourselves with our partners all around the state and see that we're really, it's difficult to interpret these results, even negative results, which we want to believe in. We still feel that we need certain precautions and to use PPE even when negative results are obtained on arrival to labor and delivery. So next slide. So determining the level of precaution for use during labor, as we just talked about, but also on the way the patient presented, whether they were symptomatic or asymptomatic when they arrived, whether they had known exposures or no confirmed exposures. So really, there's a really small subset of patients that we're using just standard precautions for. And by standard precautions, I kind of mean the quote unquote new normal, which is just a surgical mask and hand hygiene. So for patients that test negative on arrival and were asymptomatic and had no confirmed exposures, throughout their labor, we're using just standard precautions. But as you can see at the bottom there, all patients during their delivery, even those that I just talked about, we are using enhanced precautions for. So even COVID negative patients, no symptoms, no exposures, when it gets time for delivery, either vaginal or C-section, we are using enhanced precautions. The next question is regarding retesting for new symptoms in labor. So if we have COVID test negative patients on the labor floor, when would we consider retesting them during the hospitalization? And again, just like what we talked about in the last slide, it depends a little bit about their risk designation and the type of new symptom that they have. So if patients on admission had no symptoms, no exposure, and were COVID negative, we look at what new symptom has developed. If it's a fever and everything clinically looks like chorioamnionitis, the fetal heart rate tracing, the abdominal exam, their labor course, everything looks like chorioamnionitis, then we do not send a COVID retest and we treat them for chorioamnionitis. But if they develop new additional symptom, respiratory symptoms or other clinical concerns for COVID, then we do send a retest and the patient becomes a PUI with enhanced respiratory precautions. This is a little bit different and nuanced from a patient who on admission had no symptoms, but a known exposure, even with COVID negative. We're a little more suspicious of that patient. And if they develop any symptom, even fever, even though we suspect chorio is likely, we'll retest them and the patient becomes a PUI with enhanced respiratory precaution. Next slide. How does how does this COVID testing on labor and delivery affect mother-baby care? And I put : work in progress, and I realized that actually every single slide should say : work in progress, because anytime we write something down, we have to and we must go back to it and rework it when we learn more from colleagues like you guys around the state and around the country, and nothing is really ever yet set in stone. But currently on labor and delivery, co-location for all mother-baby dyads is our default. This is after shared decision-making with the patient, but really that is sort of the default pathway after this conversation. Breastfeeding or express breast milk per mother's preference is also our default for all the mother-baby dyads. In these cases where we're concerned for COVID, we arrange for separation for mother and baby within the room of at least 6 feet, and attempt to have a healthy caregiver provide most of the neonatal care in the room. This is something that we do for COVID positive moms, for COVID negative moms who have a known exposure, or for COVID negative moms who developed a new symptom in labor and repeat testing is pending. In this random caveat down here, this last bullet, for patients whose tests are pending but are completely asymptomatic and the mother is non-exposed, we really just use standard precaution for mom and baby, and we don't employ separation. Next slide. So I'm almost at the end of my time, but I wanted to go through one more poll question. What are COVID positive patients being sent home with to help prevent the spread of infection to newborns? A, educational materials about hand hygiene, and patients are recommended to use homemade cloth masks. Educational materials and surgical masks, educational materials, masks and gloves, or a combination of educational materials, masks, gloves, and gowns. Again, I don't have the right answer here at all. I think we're all really working hard to try to figure out how best to support these families once they become outpatients. Certainly education is absolutely key, and that's one of the reasons why we favor rooming in for the mother-baby dyad, so that we can teach the mothers and the additional caregiver best practice for infection prevention, but we really don't know what are the best supplies that we can send the patient home with. And if we do want to send supplies, where are we going to procure these supplies? How are we going to pay for these supplies? So next slide. Currently at MGH, we send the patient home with educational materials that are now available in multiple languages. And we're working hard to create some sort of a pandemic pack. This is not yet well defined, but some amount of surgical masks for mothers to go home with, particularly those that are planning breastfeeding, maybe some hand sanitizer and some wipes. We're working with the hospital at large and some of our philanthropic funds to try to prepare these little kits that can be sent home with every single postpartum mom that is concerning for COVID-19, regardless of their ability to pay. Next slide. And that's all for me. Thank you so much for having me, and I'm happy to take questions after the talks are complete. I'm very excited and thrilled to be able to introduce Wendy, Barr, and Elise, LaFlamme to talk about postpartum care in the time of COVID from Lawrence Family Medicine and the Greater Lawrence Family Health Center.
Good afternoon, everybody. As I mentioned, I'm Wendy Barr. I'm the residency director at the Greater Lawrence Family Health Center in the Lawrence Family Medicine Residency, and I'm joined with my fellow faculty member, Dr. Elise LaFlamme. We're both family physicians who also work at Lawrence General Hospital. Next slide. We're, as I said, coming from Lawrence up in the Merrimack Valley, and we've been seeing a lot of coronavirus in Lawrence. Lawrence is a majority Latinx city. 80% of our population is Latinx, and we are coming from the Greater Lawrence Family Health Center, which is the community health center in Lawrence, for Lawrence, Massachusetts, serving about 63,000 patients. Over 85% of them are Latinx. We provide comprehensive primary care and includes maternity care, where we deliver about 800 babies a year at Lawrence General Hospital. And we currently have 628 pregnant patients in our practice. We also run the Lawrence Family Medicine Residency Program, which has 40 family medicine residents working at the health center and the hospital. Lawrence General Hospital delivers 1,400 babies a year thereabouts and is a level 2 special care nursery. Next slide. So as I mentioned, coronavirus and COVID-19 has been a disease that has greatly impacted our community. And very early on, we really started thinking about how are we going to manage our patients in the postpartum period, both inpatient and outpatient. COVID is very prevalent in general and in our perinatal population. We currently have 569 known positive patients on our COVID registry at the health center. 21 of those patients are pregnant. What we have found looking at our registry is, while our patient population, about 60% prefer Spanish. Of the patients who test positive, 80% prefer Spanish, and this really speaks to some of the health disparities and equity issues that we're seeing. We've also noted that our patients who test positive tend to have more issues with transportation and more issues around housing and food insecurity. And this becomes barriers for care during the prenatal and postpartum periods. In the Lawrence General Hospital, as we just talked about with Dr. Goldfarb, we did implement universal screening given the large prevalence of disease in our population. We were concerned about community spread. We implemented this last week. So in our first week of screening, we screened 43 women at Lawrence General Hospital. 7 of them were positive. This gives us 16% of our asymptomatic women who presented to labor and delivery last week were positive for COVID-19. Next slide. So now that we know that we have a burden of COVID-19 patients symptomatically in our patient population, our poll question to everybody is if you have symptomatic patients with mild to moderate symptoms, patients who don't require ICU care in general, fever, mild increase of respiratory rate, mild oxygen requirement. Where are you currently caring for those patients? All right. So it seems that it's widely varied, like we're seeing with a lot of this. I think this is all a work in progress for all of us. But it seems that the plurality is the postpartum mother-baby unit, but we're also seeing a number in labor and delivery, and a number that haven't encountered this before. So this could be a timely discussion. Next slide, please. So as I mentioned, we really started thinking about how we were going to manage our moms and babies. We are family physicians, so we take care of both our moms and our babies on the postpartum inpatient and then transitioning to the outpatient period. So on inpatient, we're really recognizing the need to think about universal screening early on. We had several patients who were negative, developed symptoms during their time on labor and delivery, and we had issues with exposure. So we have implemented universal precautions for all of our parents, but we did realize we still wanted, for a variety of reasons, to know who was positive and who was negative. But when you implement universal screening, particularly in a hospital that doesn't have on-site COVID-19 testing yet, which means we have a 12 to 18-hour turnaround, we really also needed to work on shared decision-making, which we're going to talk about in a minute, so that all members of the care team, nurses, physicians, in all the specialties in all of our outpatient offices are able to speak to patients with common language, and ideally starting this process prenatally. And then when they get to the hospital, having documentation of that conversation through an informed consent document. We also had to tackle what happens for our patients who are symptomatic and who are sick in our community hospital. We are fortunate in family medicine in that many of us have been developing a lot of expertise in this disease throughout all of our patients at the hospital. Our hospital developed a COVID consult team, and several of our family physicians who also do deliveries are part of that team. And so they've been able to be the consults for our COVID-19 symptomatic moms in the hospital. The other place that we really need to look at, though, is, okay, we have family physicians who are comfortable taking care of these patients in whichever floor we decide. We really have to have the whole care team to be comfortable caring for these patients in a place that's going to be safe for the mom, safe for the staff, and be able to provide her the highest quality care. And so that's been an ongoing discussion about whether that's the maternity floor, labor and delivery, or medical surgical floors. And we're still, that would be, as everything, as we've been talking about, a work in progress. Breastfeeding is also, again, something that should be ideally started to be discussed prenatally and then throughout into the postpartum period. And then, as Dr. Goldfarb talked about, discharge planning and making sure that we have good education for our moms as they leave. And now Dr. LaFlamme is going to talk about our shared decision-making tool that we developed.
Great. Thanks for having me. Next slide, please. So recognizing that this is a really emotional time for all of healthcare providers involved in taking care of these patients, especially when thinking about the possibility of separating a new mom from her new infant, and also taking into account the significant spectrum of illness that can happen for both mom and infant with this COVID infection. We have potentially many clinical scenarios that we would need to address. So we talked with all of our stakeholders, all of the healthcare providers that are going to be involved with the care of these patients, including nursing, outpatient and inpatient. We talked to ID specialists, all of our physicians, neo, pediatrics, our OB colleagues, family medicine colleagues, and also just kind of created a multidisciplinary team-based decision on how to take care of these patients ideally. So I found that it was easier to split these patients into 4 basic categories, although, like I said, there is definitely a spectrum here. And then created a shared decision-making tool that is an optional resource for some of our providers to use for assistance in making some of the points of benefits and risks of rooming in and skin to skin, delayed cord clamping, nutrition, breastfeeding, as well as, like I said, rooming in or separation from the mother, depending on where the mom is in this illness spectrum. And also if infant is also ill, we need to think about that as well. Next slide, please. So using this kind of shared decision-making tool that I created, we have developed a consent form that after providers discuss risks and benefits of rooming in with these COVID positive moms, we are asking moms to sign. And I did see a little question, which I'm sure we're gonna answer later from Sarah Shields, but the quick answer is that we felt as a group, our multidisciplinary group felt that we could document the potential risk of infecting baby if you have a COVID positive mom who decides to room in. And the reality is that we really don't have great data on how this is transmitted. And of course, this mom could be positive one day, negative the next, positive the next. There's a JAMA article that just came out showing all of this. So it's really unpredictable, which is why I think shared decision making is particularly important here. We also were discussing when these moms are going to be going home. So this is a very dynamic process as well. This depends on the day of illness in some ways, because we see that COVID illness tends to get worse somewhere between day 5 and 10, which is a big spectrum. So if we're seeing mom kind of starting to get a little bit worse clinically on day 4, 5, we might consider keeping her an extra day if we have the resources. In general, we're thinking about early discharge for our experienced moms. And if there is some concern about blood pressure, if it's not too serious, sending them home with a blood pressure monitor and a telehealth visit in a few days. For any ill moms, as Wendy had talked about, we're currently keeping them on L&D after discussion with all of our teams, although this is always a work in progress. Next slide, please. So when we do send moms home, we had to create a plan for how they were going to be taken care of in the outpatient setting, and this goes for newborns and moms. I guess I'll talk about newborns first. So we do want our newborns to be seen in person, generally within 1 week, no matter what. I mean, I think we need to make sure there's no nutrition issue, their weight, Billy, all these things. So there's a couple different scenarios. If the mom is COVID negative and the infant is presumed COVID negative, no symptoms, we do have a well site that we're designating to be a well site within our organization. And this comes with a caveat that we know there are asymptomatic carriers, no site is 100% safe. But in that case, mom and baby could be seen at the well site. If mom is COVID positive, we're asking during the hospital that she sign a consent form for a healthy caregiver to be able to bring the infant to their visit. And this would be at our COVID designated site, which, you know, that's another caveat. That asymptomatic healthy caregiver could very likely be an asymptomatic carrier, especially if they're living with that mom. So I think these are a lot of issues that we're doing our best in our world of gray right now. Most moms, we really want to be seen by telehealth visit, and that's sort of our standard care plan after discharge right now. And there's a lot of things we've found that we can do within our telehealth visits pretty well, actually. If there's any concerns that come up during the telehealth visits, we have mom come in for a visit, and if she's COVID positive versus COVID negative, she would either go to our well or COVID site. We typically see our post-op patients after C-sections within about a week at our health center, and we're doing these standardly telehealth unless there's a concern on discharge or during the telehealth appointment. As far as contraception, we really are encouraging LARCs, and we have a system set up in the hospital pre-COVID for Nexplanon placement during hospitalization. We also use Depo often, and you know, we have a whole system set up if patients prefer to wait a few months for these. So that's a whole other presentation, I think. We do have a COVID registry, as Wendy mentioned. We're following all of these patients. We have a nurse that is dedicated to following up on how they're doing clinically during their pregnancy and postpartum. And I did want to mention that I think postpartum depression is something we should really keep on our radar right now because of the increased isolation. Those moms aren't going to be having like family and friends coming to visit them, and we could be seeing an increased risk of postpartum depression. So we are trying to move to a 2-week postpartum standard telehealth visit to check in with these moms. Next slide. So I would like to turn this over to Ron Iverson, who's going to moderate the open question and answer portion.
Great. Amazing presentations. Thank you guys so much. Definitely learning a lot with what you guys are presenting here. We've been working here in the background, writing down the questions that people are asking, and I wanted to just sort of go through that list with everybody now. So first, I wanted just to see if Ilona could address what we mean when we say enhanced precautions, just so we're all saying the same thing.
Sure. Thanks, Ron. Yes, I should have defined it better. Enhanced respiratory precautions is what we call wearing an N95 respirator or PAPR, eye protection, gown, and gloves.
Great. Thanks. I'm going to go down the list now of questions, and I also encourage people, if I misrepresent your question, please come off mute and correct the way I'm saying it. I don't mind that at all. So first, there was a question regarding what you're doing regarding testing or screening partners. From TP19.
At this time, we are not testing partners. We screen partners when they arrive with the patient for symptoms, known COVID-19 status, or known exposure, and the visitor policy it allows for an asymptomatic non-COVID-19 positive visitor to stay with the mom, but certainly any visitor that endorses symptoms is not allowed to stay and be a visitor on labor and delivery. But at this time, we're not rolling out universal testing of the partners.
Okay. And does that also apply to what we call a healthy caregiver?
Right. We're not testing anyone except for the mom and then the baby if the mother is positive.
Right. I might have missed it. Did you say what your sensitivity and specificity are on the tests that you use?
I don't have the specific numbers for our tests. I don't know that we have that data yet even available. I know from just reading in general the nasopharyngeal swab, the sensitivity is somewhere between at lowest 70%, at highest 90%. Specificity is higher in the mid 90s, but I don't have any more accurate of a number for our site specifically.
Got it. Thank you. From Martin November, he asked, isn't the issue more about availability of testing rather than the testing strategy?
I can speak a little bit about availability of testing. So that has been a big issue for us up in Lawrence. So we, right now as a hospital, the testing is only through the local hospitals. So Holy Family Lawrence General. The testing generally is being only done for categories 1 and 2 of the CDC. So that is healthcare workers, people who are high risk of being hospitalized, people who are hospitalized, or in other institutional situations. So we've included in that pregnant patients so that we're able to get that, but that actually has been an ongoing conversation where even last week we had some pregnant patients declined and then we had to send them back. And then the homeless. But it's the availability of swabs. If we universally screened everybody, we would run out in a week. That was at least a couple weeks ago, that was one of the concerns.
Mhm.
And right now we're sending our tests out. We don't have them on site. I know we are supposed to be getting rapid tests sometime this week. We're all very anxious for that. But again, we only had 200 swabs total for the rapid test. So again, we're only going to be testing the pregnant moms who we think are going to deliver sometime in that 12 to 18 hours and people who are being admitted to the hospital that we feel like we need to know the test results quickly to be able to cohort them appropriately.
Yeah.
So yeah, so when you say it's hard to get tests for most people, I mean,
yeah,
as
you
an
bring out
outpatient doc, we're not.
you bring out a great point that there is a difference between the perfect world and the world that we're all living in as we do this. So thanks for pointing that out. From H. Aslam Kasaroglu, when you say enhanced precautions for all patients during delivery, that has also included asymptomatic COVID negative mothers. And what is the PPE for negative asymptomatic patients? I think that was covered in a slide to say that you did not use the enhanced precautions, but please let me know if I'm right there.
So we use standard precautions, just a surgical mask and gloves, or a surgical mask and hand hygiene for the care of COVID negative, asymptomatic, no known exposure patients all the way through labor until delivery. At the time of delivery, at the moment, everyone is, whether their test was positive or negative or pending, is the precautions that we're using are the enhanced respiratory precautions.
Okay.
And in Lawrence, all deliveries, N95, face masks, gowns, full precautions at delivery. During labor and postpartum, we are having everybody wear masks, face shields, eye protection, and gloves for all patients. I'd highly encourage that as the residency director who had to put 6 residents on quarantine because they didn't have eye protection when we had a patient unexpectedly become positive during her postpartum period, and we had to go find everybody who had seen the patient in labor. Ironically, the delivery team was fine because they had all the good protection, but it is really hard to expect a mom in labor to wear a face mask. And so if you look at the CDC guidelines, a big change point is if either both people are masked or if only the provider is masked, that you have eye protection. So lesson learned.
Yeah, great point. Thank you. Sarah Thibodeau wrote a question and there's some answers. So I'll just run through that real quickly and feel free to kick in if you have something else to either chat or say. For those patients who test negative at Lowell 48 hours before their scheduled case, we are not using N95s for their C-section or induction of labor. Are others doing the same? So Katie Rowe said the same is being done at Melrose Wakefield. From Aquino, at Lawrence, we are using N95 even with negative because we had a patient that was negative and became symptomatic, we just said, during their stay that turned positive. From Jay Zocco, we are using N95s for all deliveries, universal testing too, due to potential for false negative results. Answers. This is from Elizabeth Kester at BIDMC. We're wearing N95 masks for all deliveries because every delivery has the potential to lead to a neonatal resuscitation immediately after delivery, which may involve procedures that are aerosolizing. Also in the operating room when caring for a patient with COVID-19 or PUI, in the operating room when general anesthesia is likely to be used, regardless of patient symptoms or testing, in the operating room or LDR while pushing, while caring for a patient with COVID-19 or PUI, and during collection of a nasopharyngeal swab on COVID-19. Thank you for that answer. From Lena Bautista, is that due to the need to conserve? I think it's regarding N95s. And from Sarah, thanks everyone. It is to both conserve PPE because we're considering this enough information to not use the enhanced precautions. Okay. Next question. This is for me. What percent are coming up at Mass General positive from your asymptomatic patients?
So the numbers have been actually harder to come by than we thought. We had hoped that the way we order the test for asymptomatic patients would be a searchable field later to generate data, but it's proved to be, like everything with Epic, really, really not user-friendly for reports. But best as we can tell, since we started about 10 days ago, we've tested approximately 50 patients, and we've had 3 positive asymptomatic patients.
Thank you. Yeah, it's true that Epic can be a little bit odd in terms of data collection. Okay, from Lena, what about the possibility of triple diagnosis? Not sure if reported on L&D, but outpatient med and strep and flu COVID positive has been seen, so no longer rule out COVID if flu positive, for example. Oh, Lena, Ilona, do you want to just say what you guys are doing there?
Well, we're taking lead from our infection control and infectious disease colleagues who have said on surveillance of the hospital since this began that we really weren't picking up any more flu cases, that we're no longer co-swabbing. At the beginning, for the first few weeks, anyone who was being swabbed for COVID-19 was also having an RSV and a flu swab. But I guess based on the surveillance of that protocol, infection control has decided that we're not considering flu anymore in this season.
Got it. Thanks. From Toffee D, how frequently are you testing COVID negative patients during the prenatal period? Ilona.
Sorry, what was the question again?
How frequently do you test COVID negative patients during the prenatal period? I'm not sure exactly.
Yeah, we're not routinely testing patients who don't have any symptoms throughout their prenatal course. The only time we're testing asymptomatic patients is when they are planned for admission to the hospital or arrive for admission. But we are testing any pregnant patients that report symptoms antenatally. And then once we're following, much like Lawrence, we have a tracking system where we're keeping track of all of our COVID positive and PUI moms and checking in with them every couple of days. So we have a pretty facile system to return to patients and offer them testing once the testing guidelines change. And most recently, the testing guidelines allow for testing of any pregnant woman who has one of the COVID-19 symptoms.
Got it. Thanks. From Race 66. So if the patient is positive, is she supposed to breastfeed or pump and have someone else give the baby the milk so that she can stay 6 feet away?
I can answer that one. This is Elise. So I don't think that there's an answer, which is why shared decision-making is really important. There's no reports of the virus found in breast milk. There are a few reports of antibodies to the virus found in breast milk. So you could even make an argument that maybe it's protective. But if a mom is COVID positive with symptoms, you could make an argument that there's probably an increased risk of transmission and give the mom the option of pumping milk and having a healthy caregiver feed the baby. And again, caveat with healthy caregiver. We don't really know if that person's going to develop symptoms in the future. But then the shared decision-making tool that we have has basically 3 options, and parents that prefer to accept the risk of transmission and maximize mother-infant bonding, we would recommend that the mom wears a surgical mask, washes her hands and breasts, ideally with soap and water before she breastfeeds the baby, and understand that there's a risk of transmission it's uncertain but possible.
Great. Thank you. And I'm conscious that it is 12:51, so I think we can get through everybody's questions here. What are you using for asymptomatic patients before their COVID results are back? Ilona.
Yes, so this is also nuanced, and as I was mentioning in my slides, it really depends on the answers to a bunch of questions that we ask when they first arrive. So if patients are completely asymptomatic, have no known confirmed exposures, and their tests are pending, we treat them with standard precautions, meaning just a surgical mask and hand hygiene, until delivery, at which time, regardless of the test results, positive, negative, pending, we would do the enhanced respiratory precautions with the N95, face shield, gowns, and gloves. Patients that are COVID negative on admission but endorsed a symptom or endorsed a known exposure, we used enhanced precautions for those patients throughout their labor course.
Got it. Thank you.
And then in Lawrence, because that category is a bigger category for us because we have 12 to 18 hours of that until we get our rapid tests, is we use the eye protection. So that's important. And then if they deliver, because a number of them do deliver, that's, I had someone saw a question about what's the yellow category on our shared decision-making tool. And that's that asymptomatic patient who's been universally screened, but we're still waiting for results. And in our institution right now, that's a 12 to 18-hour window. And so in that situation, there is a shared decision-making conversation about whether mom wants separation from the infant until she gets her test result back versus having the infant stay 6 feet away, and kind of we treat her kind of as presumptively asymptomatic and positive until we get the negative result, kind of the way that's seen.
Thank you. From Lisa Capra, is there any type of outpatient home service for families who are taking a newborn into a household with ill contacts? It's for either of you guys.
I do not know of any. I'm sure, I know that there are some housing options for people that are adults that are sick that want to quarantine from their families, but specifically with the newborn situation, I don't know of any.
Great.
I haven't heard of anything like that.
I haven't heard of anything either. I'm not watching the chat. I'm answering off of another document I created. So if please watch the chat if somebody brings something up. From CL Green, we deliver 500 patients a year. Our OB docs are recommending delivery off of the unit. This means we have to take all our supplies to a critical care unit on the other side of the hospital and have a minimal competent backup for concerns. What is your recommendation? Do you separate your L&D area to COVID or non-COVID, or do you recommend deliveries off of the OB unit? Both of you, please.
That's a, oh, go ahead. Sorry, Wendy, go ahead.
I mean, so 500 deliveries, I'm thinking it's a community hospital. I keep them on the labor and delivery unit. That's where you're going to have your equipment, your good nurses, safer for the patient. I mean, when we first started this 6 weeks ago, I look back, we initially made plans calling labor and delivery a clean space. And I mean, I just mentioned 16% of our patients who are asymptomatic are testing positive. I think if you have significant community spread of COVID in your community, your L&D is just like every place else. You got to assume there's coronavirus there, and you take care of the patients in the best place where they can be. We did initially, when we had a lower prevalence of coronavirus, again, about a month ago, we had a dedicated labor room that had negative pressure that we were kind of using as the aim for that. So I guess if you have a low prevalence community, that would be an option, is to say, hey, this labor room is the labor room we're going to put all of our PUIs and our COVID positive moms for delivery. But I wouldn't, I'd make sure the moms have the best, I mean, the moms should get the best care possible, whatever disease they have. I think, you know, you'd want to keep it on labor and delivery.
Okay. Ilona, are you also delivering L&D?
We decide based on the maternal condition. So if she is COVID positive, but minimally symptomatic from COVID or asymptomatic, and her primary issue is labor and delivery related, we keep those patients on labor and delivery. If the patient is decompensating from COVID-19 illness standpoint, we have a pretty low threshold to move our operation to a COVID unit, because there we found, a good partnership and good support with our internal medicine and critical care colleagues. And of course, it is definitely disruptive for the labor team to move, but maternal respiratory support and ability to quickly move to intubation if that was necessary, we felt was going to be safer off of our unit.
Great. Thanks for all those answers. I'm going to move a little bit more into the second presentation now. Sarah Shields had asked a question about informed consent, which was answered in real time. Thank you to Martin November for sharing the JAMA article for Lena. Sarah Shields asked another question: does everyone have to sign the informed consent, or only those who choose rooming in?
Yeah, so only those who choose rooming in are signing the consent. I think the idea is that we know the risks of the benefits of breastfeeding and time spent with mom, maternal infant bonding. We don't know the risks of transmission yet. So we're working with the information we have, and given that there's an unknown risk of transmission and what that could look like for the baby in general, I think that's why we're having mom kind of not only verbally, but also in writing consent.
Thanks. From Melanie Greenman, does anyone have information about reimbursement on LARCs? I'm going to move that along because we're going to do a presentation on LARCs hopefully next week. We're seeing what we can do, and we hopefully have that answer for you. And then it says from Sarah Shields, have you had any luck with MassHealth to quickly cover home blood pressure cuffs for pregnant moms? We have a 2 to 3 week delay in being able to get them. Do we have an answer?
I don't know specific to postpartum yet. This is like rapidly developing over the past 1 to 2 weeks. So, but I have been prescribing them for my other MassHealth patients and haven't heard of a problem yet.
Great.
We may also have it a little easier. We have a community health center based pharmacy that we can dispense blood pressure monitors out of. So that may make a difference just in how things get processed with MassHealth.
Okay. I think we have just time for one more question. We're just bumping up on one, and I want to be respectful of people's time. If the mom is COVID positive and separates from the baby, where do you place the baby? And do you allow dad to visit both going back and forth?
If the mom is positive and the baby's not, is that what you said?
If the mom is positive and the baby has been separated, yes. Where do you place the baby in the room?
We have a separate newborn nursery for PUI babies, which I think is and then if baby tests negative and mom chooses separation, if she's COVID positive, then they would also go into a healthy baby nursery.
Great. And what about dad?
I believe dad is allowed to visit the baby and have mask and hand washing, hand hygiene before caring for the baby if he's a healthy caregiver.
Great. Last question here, and then we're going to say sign off. But Kari says, are you retesting patients who are positive and discharged prior to delivery or admission? Discharged who are positive and discharged may be cleared prior to delivery and admission, or following a sensitivity rule only?
We are retesting. So even if someone was previously positive and then cleared their infection and had 2 negative tests, but then arrive to labor and delivery for admission, we're retesting them.
Great. Thanks for that.
And we're
gonna
doing the
turn
same
it
at
over-
Brigham and Women's.
Great. I'm going to turn it over to Audra and Barbara. Thank you so much for all these questions. They were really, really helpful.
Okay, so thank you, everyone. I just want to remind you that there's a post-meeting survey. This is really provides us helpful feedback about what we did well and also what topics you'd like covered in the future. Here's the URL, and if you are not on our distribution list, if you think you are not on our distribution list, we're going to leave the chat box open for a couple of minutes, so you can just enter in your email addresses, and we'll be sure to add you, and we'll also send you this link. So, so thank you, everyone, and we look forward to seeing you next week.
Yes, thank you.
Thanks, everybody.
Thank you.